Good. So in the interests of time, and because I'm hoping that we'll get on with a really interesting discussion, I'm going to kick off today's seminar. Welcome, everyone. Those of you that are joining and are punctual, and those of you that will still join halfway through. This webinar is part of the Epidemic Ethics series, which most of you hopefully will know. It's a really exciting initiative that is run from WHO in collaboration with University of Oxford and others around the world, where we're trying to foster engagement in the ethics of epidemics and pandemics. In this panel discussion, we'll host three exciting speakers who will engage with us about the political economy of the COVID-19 pandemic and how that has impacted countries' ability to navigate the pandemic. The reason that I thought it was really interesting to focus on that slightly kind of broader topic than just the narrow ethics topic is that how we think about issues such as justice and fairness and the way in which we can enact justice and fairness in practice in the context of health is invariably constrained by the structural conditions within which our governments and our healthcare systems operate. And so today's speakers, each three have something to say on that topic. Possibly our perspectives are somewhat skewed because all three speakers come from South Africa. And so our contributions are probably skewed a little bit by our particular location. But I think what is interesting in the case study from South Africa is that we've had quite a lot of government activism and activism by civil society sector that has tried to shed light on the political economy of the pandemic. So what I hope to do, and where I hope to end off, so I'll get all three speakers to speak a little bit, to give their perspectives. We'll mediate a discussion that we have prepared, and then we'll have questions from the audience. And what I will ask, and where I hope to end off, is a discussion with these three speakers about what they think should be the non-negotiables for African governments surrounding the new pandemic treaty, which obviously is a topic of ethical concern. But before we start, just some housekeeping rules. So I'll try to keep an eye on the chat function, but it would help a lot if you could just post specific questions for the panelists in the Q&A function. And if you see questions that you like posted there, you can like them, and that will prioritize the questions asked. Although, of course, I might also use chair's discretion to prioritize particular questions that I think are more important. So note that the seminar is being recorded and will be made available on the Epidemic Ethics website later this week. Now, just in order to introduce ourselves, I am the panel chair for this webinar. My name is Jantina de Vries. I'm a professor of medicine and director of the ethics lab at the University of Cape Town. In the ethics lab, we center Africa as context and driver for bioethics to disrupt and shape global health research and innovation. In today's discussion, we do so by drawing into focus ideas around fairness and justice that are always constrained by the broader structures of the world. I am joined by three excellent speakers. Dr. Lauren Paremoer is a senior lecturer at the University of Cape Town, and she's a member of the People's Health Movement of South Africa. Her research focuses on health activism, global governance for health, and political mobilization aimed at realizing social citizenship in societies of the Global South. Dr. Marlise Richter is an honorary lecturer at the School of Public Health and Family Medicine at UCT, and a research associate at the African Center for Migration and Society at the University of the Witwatersrand. She has worked in health and human rights focused organizations for the past 20 years, including the Treatment Action Campaign, the AIDS Law Project, and the Sonke Gender Justice. Dr. Safura Abdool Karim is a public health lawyer whose research has focused on improving health through law. She's currently a Glide Fellow at the Berman Institute of Johns Hopkins University. She was a member of Africa's CDC Vaccine Delivery Alliance and Partnership for Vaccine Manufacturing, advising on issues related to ensuring equitable access to COVID-19 vaccines on the continent. So I will hand over to the three panelists. Lauren will start, and then followed by Marlise and Safura, who will each give us a 5-minute short statement of their views or experiences, and then we'll mediate a discussion. Lauren, over to you.
Thanks, Jantina, and good day to everyone. Thank you to the Epidemic Ethics Network for the invitation to participate. So before this webinar, Jantina said, these are the questions we're going to discuss, and I prepared some comments, but something struck me as she was framing the topic again, which is about political economy of COVID-19. And that is that when we think about political economy, we often think of things that can be bought and sold. And I think when we speak about the political economy of COVID on the African continent, one of the things to think about is services that are produced but not sold, not traded, not sold for profit. And that's quite often what feminists would call the social reproduction work done by women in the community, in the household. So I think the first thing to think about in terms of pandemics and the African experience with pandemics is that there was a lot of unpaid, invisible, and unsubsidized work done by women, but also by community health workers in their households, particularly during lockdowns, but also trying to figure out how to get people access to medical services they needed. And this might have been COVID related, but also routine services, access to HIV services or TB services. And at the same time, given that so many countries went into lockdown, South Africa was quite extreme. Many other African countries were less extreme. But given that countries went into lockdown, these women, one, they had responsibility of caring for others and kind of subsidizing the healthcare system, but the healthcare services that they or we needed were kind of inaccessible, right? So reproductive health services and so forth, for example. So I think one thing to think about in this political economy picture is the invisible workers that help to carry us through the pandemic. Then the second thing that I want to speak about very briefly is just the more visible side of the political economy. And that is, I guess, a conversation that's often thought about in terms of where the African continent and African countries sit in the context of the global political economy. And in that sense, I would say that the pandemic exposed the many ways in which the global political economy is broken. And in particular, I think it exposed the fact that because of long periods, decades of African countries not being able to develop their medical manufacturing capabilities, many other things too, but one would certainly be medical manufacturing capabilities because of structural adjustment programs that defunded health systems. African economies, African countries were very much at the receiving end of a system that treated them within a framework of charity rather than solidarity during the COVID-19 pandemic. And so many African countries faced a situation where, despite for many decades advocating for developing capabilities to produce medical services and medical technologies locally, they had not yet secured those capacities. And during the pandemic, that left them dependent on donations or solidarity schemes like COVAX, for example, in order to access vaccines. Quite often, even medical products that were fairly simple couldn't be produced locally. So, for example, masks, because of intellectual property restrictions and so on. So I think the point I want to make very briefly about the visible political economy is that structurally, it exposed African populations to higher risks of infection. And when people did get sick, it exposed them also to a disease course where they very often didn't have access to the medical services they needed to survive. And that's not disconnected from a legacy of imperialism, colonialism, structural adjustment programs, and I think in the contemporary period, neoliberal globalization, which have left African economies focusing on exporting primary commodities, food, wood, minerals, metals, and so on, rather than manufactured goods. And then very briefly, just in terms of the final chunk that I wanted to flag in relation to political economy, I think given that experience that African countries had during the pandemic, there is a renewed vigor by African leaders, African governments to advocate for systemic reforms that would allow African countries to champion their own research and development agendas, to develop local medical manufacturing industries, to impose obligations on developed countries, not to help them in terms of a charitable mode of help, but actually to engage in things like technology transfer, open licensing of intellectual property, and so on. So there are all these proposals that African governments are championing post-COVID, and they're doing that in a very serious and sustained way in two processes currently ongoing at the World Health Organization. The one is a set of processes aimed at reforming the international health regulations. These are regulations that have existed for some time, and they govern how the WHO leads countries in responding to outbreaks, but also public health emergencies of international concern. And then the second forum in which African countries have been very active in championing equity proposals that would change the structure of the global political economy, particularly in relation to health interventions. That second progress is sometimes referred to as the Pandemic Accord process, the Pandemic Treaty process. It's also referred to as the Intergovernmental Negotiating Body on the Pandemic Accord. And that process is aimed at establishing a new instrument that would address the structural blind spots and pitfalls that led to equity gaps during the COVID-19 pandemic. So as I said, in both forums, African countries have been quite proactive in flagging the interventions that would be needed to change the shape of future pandemic responses, and in particular, to change their shape so that African countries have greater local and regional capacity to produce the goods and services that are needed to respond to outbreaks, health emergencies, and pandemics. Finally, just closing off, I think one of the areas of concern in relation to those two multilateral processes at the World Health Organization is that many of the equity provisions being tabled in those forums are being, at this stage, codified as suggestions, so kind of soft law suggestions on what countries might want to do, might want to encourage, and so on. And I think given the experience of the COVID-19 pandemic, it is worth mentioning that the Africa Bloc is quite strong in pushing back against that and is saying, well, we need legally binding obligations that ensure equitable responses, just and fair responses to pandemics. And I think that's quite remarkable, and it's something we can circle back to, I think, during question time. So I'll leave it there and then hand back to you. Thanks, Marlise.
Good afternoon, good morning, everyone. It's a pleasure to be able to speak to you a little bit about the work that the Health Justice Initiative was involved in during the pandemic. I worked at the Health Justice Initiative from 2021 until a couple of weeks ago as a researcher. And I was very much involved in the advocacy and litigation that we were involved in around our campaign, what we called the open contracts case, which fell into a portfolio of work on pandemic transparency. And what I want to do this during my 5 minutes, I'm going to quickly set my timer, is to, sorry, let me just make sure that I don't go over my time, is to speak about the open contracts case in particular. And I just want to preface it with two references to some of the other cases that we were involved in. One was on open decision making, and that was specifically advocating that the scientific committees that were giving advice to the South African government, that their memos, the advice that they were providing to the Minister of Health, that would be put into the public domain very quickly after providing it to government. And the second case that we were involved in was trying to get to the bottom of what happened to some of the leftover vaccine stock that a big trial, a clinical trial in South Africa called the Sisonke trial, using Johnson & Johnson vaccines, where some of the leftover stock went, and that we determined that it was given to elite athletes and government, people in government, which there wasn't sufficient information in the public domain. So having used access to information legislation in South Africa, we were able to ascertain more information about these cases, and we eventually withdrew them. The third case that progressed, and what I want to speak about very briefly, is requests to government through the access to information frameworks to publish the contracts that they had signed with vaccine manufacturers during the pandemic. And our main argument was that the lack of transparency on decision-making, as well as with contracts, undermined the robust management of the pandemic. So we launched the case and we started our legal processes around accessing the information about the contracts in early 2022. By that stage, South Africa had received many vaccines. You can see that we didn't know exactly how much money we had spent on vaccines, but we know from some of the information in the public domain from Treasury is that that at least 10 billion rand was allocated by our Treasury for vaccines in 2022. But yet, seeing that these contracts had loads of money, people in the public, they were not placed in the public domain. And we argued that the public administration, it was our taxpayer money, means that these contracts and the negotiations around them, that they must be fair in terms of public administration processes, and that there was a duty on government to procure goods in a process that was fair and equitable. And we wanted this information to be automatically placed in the public domain. And not have the assumption that pharmaceutical companies can enforce non-disclosure agreements on governments. So basically, our ask was for any contracts and meeting memoranda with all the entities that you see on your screen at the moment, that they are placed in the public domain. We argued in our court papers that vaccines are essential to the global response. It's absolutely important in terms of population trusting government, to foster that trust. There shouldn't be a sense that important information is withheld. And I think that vaccine hesitancy and distrust in government was fueled by the fact that government insisted that the provisions in these contracts were secret. We have strong provisions in our South African law about contractual transparency, and also within the South African government in some of the procurement, and I think our panel will speak a bit more about that, there were severe allegations around corruption that is still being prosecuted and coming to light. So the sense of having to foster trust was a key argument that we made. We knew in what wasn't in public domain is that South Africa and some African countries were paying inflated prices for vaccines as compared to the global north. South Africa had to sign quite broad indemnification clauses that would put the burden of responsibility on the government rather than pharmaceutical companies for harm through these vaccines. And South Africa was also prevented from imposing export restrictions for vaccines. And we know that early on in the pandemic, some of our vaccines were exported to Europe when we were in great need of it. I see my time is finished, and I just want to in 30 seconds just speak about the fact that we were eventually successful in the case. The judge ordered that the contracts would be provided to the Health Justice Initiative within 10 days of the court of the judgment, and then a consortium of organizations analyzed the contracts, and you can see the report there that you can look at in more detail. And overall, we saw that contracts were very one-sided. It favored multinational companies. That there were heavy demands made on governments in our country, in South Africa specifically, and that there was very little leverage that the South African government had if the pharmaceutical companies didn't deliver on time. There was the prices that were involved, that were disclosed in the contract, showed that we paid significantly more for some of the vaccines. You can see that we paid 15% more for Johnson & Johnson as compared to the EU, and that South Africa was charged more than the African Union was charged, almost a third more. This enabled, ironically, this case enabled Department of Health officials to be able to speak out about it. Here's a news report about our Deputy Director General of Health, who said quite candidly that we were screwed over vaccines and that they couldn't speak about it because of the non-disclosure agreements. So we're hoping that this case would leverage more demand in other countries for their contracts to be disclosed, and that it would have knock-on effects for procurement in our national health insurance scheme, and then, of course, as Lauren mentioned, the pandemic treaty negotiations. I'm going to end off just to note where you will be able to access the contract and some of the analysis around it. I'll also put this in the chat box, and then a compendium of pieces that the Health Justice Initiative produced around very specific pandemic lessons learned in South Africa. So let me end off there. Thank you.
Thank you, Marlise. Wonderful kind of from Lauren's broad framing of concerns around the pandemic and the pandemic lessons, and the importance of ensuring that African countries and African governments are supported and empowered to take charge of research and medical manufacturing agendas. This is a good case study of describing why that is so important, I think. Safura, over to you.
So thank you so much, and I appreciate the opportunity to speak today and to also engage in a robust discussion with the other panelists. I think following on from what Marlise and Lauren have discussed, I think I want to begin by framing the situation around vaccine nationalism, that is the gross inequity in vaccine access and the kind of hoarding and monopolizing of vaccine supply by high-income countries as an artifact of conduct by two groups of actors. The first is that there were high-income country governments that invested a lot of money into vaccine development and in exchange attached a very long string, which is, we'll give you the money to develop these vaccines, we'll remove all of the risk and often use taxpayer money, but in exchange, you're going to give us the doses first if your vaccine works. And that was what sowed the seeds of what has now been termed vaccine apartheid, which is where many populations in high-income countries were able to receive 2, 3, 4 doses of vaccine before majority of people in low and middle-income countries were even able to access one. But there was another group of people that were deeply influential in creating the system and are now actively engaged in perpetuating it and maintaining it for the next and future pandemics. And that is big pharmaceutical companies. I think Marlise's case study illustrates just how clearly they have shaped vaccine equity, how powerless low and middle income country governments are against these vested interests. So what I wanted to touch on in my remarks is sort of something that I like to call the many flavors of vaccine nationalism and how they've mutated during the pandemic. So I've outlined what it started as. It started as, we're going to invest and monopolize supply. But after these countries had been able to get their first and second doses, being able to vaccinate a majority of their populations, I think many of us assumed and thought that doses would be making and trickling their way to low and middle income countries. That hasn't been the case. In fact, someone at the WHO, and I forget their name, had a great way of explaining this. He said, high-income countries haven't taken a me-first approach when it comes to vaccines and COVID. They've taken a me-first, second, and third approach. And that is absolutely correct. We see that even till now, countries in high-income countries and high-income governments are continuing to purchase fifth and sixth boosters. They're commodifying and treating COVID vaccines as though they are not a public good, but very much something that is to be purchased and given to their own populations without regard for other countries and for the needs of low and middle income populations. And what that meant is that many people in high income countries throughout the first and second years of vaccines being available were getting fourth boosters, while healthcare workers, frontline healthcare workers in low income countries who were relying on COVAX were unable to get access to doses of vaccines. And the way this played out sort of subsequent to this, once there was a lot of public pressure on these high-income countries to distribute their doses, was that a charity model was adopted as opposed to a solidarity model. And I think that's something that Lauren alluded to. So once they had decided that they were ready to donate these vaccines to low and middle income countries, as opposed to empowering them to buy them, as opposed to recognizing that they had monopolized supply, what ended up happening was that many of these countries would donate almost expiring vaccines with almost no notice to African countries. And as a result, many of these countries were unable to properly plan to deliver the vaccines. And that was one of the huge problems we discovered in AVDA, is that thousands of doses would just arrive with no notice, maybe 2 or 3 days notice. They'd be expiring in a week or two, and governments who had very little capacity to deliver these vaccines were suddenly scrambling to try and create supply chain networks. They didn't know what kinds of vaccines they were getting, so they didn't know if they needed the kind of cold chain management that was necessary for a Pfizer, or if they could rely on something like a Johnson & Johnson that could be stored in regular fridges. And all of this led to fairly high levels of vaccine wastage. Because if vaccine doses are expired and you're giving people almost no notice of the need to distribute them, of course, these governments are not going to be able to deliver it. But that in and of itself became a weaponized narrative that has persisted. This idea that vaccine apartheid and vaccine nationalism doesn't exist because of high-income countries and the vested interests of big pharma. It exists because of African incompetence, because we gave you the doses, we donated them to you for free, and you couldn't deliver them. And so I think this is a reflection of how vaccine apartheid and vaccine nationalism and just global inequity in accessing novel health technologies is not something that is specific to COVID. It is not something that is over. And I think we are seeing now, as these two initiatives, these multilateral negotiations are happening that Lauren described, a perpetuation of the circumstances and infrastructure that enabled this vaccine nationalism and this vaccine apartheid to flourish. And all of that is to say that if we continue on this trajectory, it is very likely that when the next pandemic comes around and the following pandemic comes around, we will see what has happened and played out during COVID be repeated, which is something that should concern us all immensely. Thank you.
Thank you, Safura. So the first question that I would like to ask you, so both Lauren and Safura have spoken about a solidarity model, not a charity model for, I guess, vaccines in this case, but more generally when we think about what is required to address pandemics. My question to you is, can you, maybe Lauren first and Safura and then Marlise, tell us a bit more about what a solidarity model would look like, and how that is different from the charity model?
Thanks, Jantina. So I think one of the key elements of solidarity is something that Safura touched on. So when she mentioned vaccine donations as an act of charity, one of the things that's so striking from that example is that there's a clear kind of hierarchy. There's the giver who has all the decision-making power, and there's the receiver who's kind of in the dark and not quite sure what's happening and just gets called up and told, hey, I have a gift for you, isn't it great? And that comes with a whole set of complications for the receiver, who is, in this case, it would be an African government that is juggling many multiple crises, and all of a sudden is saddled with having to demonstrate competency in receiving this gift that has logistical challenges, human resource challenges, and so on. So I think what Safura's example nicely illustrates is that charity is where there is very little engagement. There's certainly very little engagement in terms of regarding each other as equals. And there is beneficence, so it's not necessarily, charity isn't necessarily something that comes from a negative place, a bad place in terms of valuing dignity and so on. But it's trying to project goodness without equal regard for the other parties involved in the project that you're trying to collaborate on, or the project that you're trying to manifest, right? So for me, solidarity is about working together, about democratic and transparent decision-making. It's about working towards a common goal. And it is also realizing that the parties have different capabilities, but that doesn't mean that a party with, let's say, fewer human resources or lesser technological capabilities, that they don't bring anything to the table. There's also knowledge, there's expertise, and so solidarity for me is also about realizing that parties should bring their strengths to the table, but also where some parties are stronger than others, that they have to kind of give more, do more, always in consultation and in joint decision-making with the other. And so I think one of the, if we think of a kind of institutional context, one of the ways in which that could be manifested is in the multilateral system. It could be in a forum like the World Health Organization, where actors have different capabilities, but member states come and collectively decide on an agenda and then decide what they can contribute. I think it's less possible in a mechanism like COVAX, for example, which was a kind of super public-private partnership established to distribute vaccines, where it wasn't always clear who was making decisions. And often when it was clear who was making decisions, it would be actors that had more political power and resource capabilities than others and would make unilateral decisions. So COVAX is kind of the institutional charity model. I would say something like the World Health Organization has the capability of being a kind of more solidarity-based institution. Thanks.
Right, maybe Safura, and then Marlise, I don't know if you want to comment as well.
So I think that the one thing that has been demonstrated in almost every major epidemic that we faced is that the model of commodifying health interventions doesn't work. And it really is not fit for purpose when it comes to something like life-saving health technologies. I think we saw it during the HIV kind of movement around access to medicines, and I think we're seeing it again now. But what we haven't seen is kind of a really viable alternative model to this. For me, the original working draft of the Pandemic Accord, which is the treaty that's being negotiated, had some infrastructure that could move us towards a real model of solidarity, because it was attacking multiple prongs. So the first thing it did is it said, we recognize there's all this World Trade Organization infrastructure. We realize that there's all these intellectual property protections, but this Pandemic Accord sits above those things. It sits separate to and above. So you can't rely on your WTO protections and obligations to prevent or escape your obligations to ensure equitable access to life-saving technologies. And I thought that was very powerful. It did a couple other really important things, such as creating sustainable solidaristic financing mechanisms. So in other words, it created a pool fund that wealthy countries and middle-income countries could put into based on their capability, and that could be used to fund pandemic responses and pandemic preparedness globally. And what that signals to me is a sense of we're all in this together, that we need to all contribute to making sure that we're all safe. And I think that was where the wheels came off in COVID-19 vaccines, because we started off and we were like, everybody can be infected. There's no such thing as borders. We're all at risk and we're all in this together. But as soon as the vaccines became available, borders very much came with them. It was the sense of, I need to protect my country and my population. Once I've done that, I don't care what happens outside of my country. And I think that's really the issue here, is there was a moment of solidarity in the pandemic, but it very quickly gave way to this kind of nationalism and the sense of it's not about everybody else, it's just about me. When we know that this is not the first pandemic that's going to happen like this, we're going to be experiencing more and more of these cross-border epidemics as we go forward.
Great,
I think
Marlise?
I'm going to follow up on that, because when what Safura was saying, I suddenly were reminded about the slogan that we used on quite early in the pandemic. So I was involved in some of the local level activism within Cape Town, and some Lauren and I were part of the People's Vaccine Campaign, and people, colleagues on this call would remember that governments and that activist groups would always talk about no one is safe unless everyone is safe. And that had very, very much, specifically in the beginning of the pandemic, it was about mask wearing, being sure that you keep yourself safe so that you can keep others safe. And I think that mantra became much less visible, and its popularity dwindled to being almost non-existent when vaccines appeared. And I think the vaccine apartheid that we saw, with the really immense inequalities that we saw in terms of the statistics and the maps, with the heat maps that showed how vaccines were being rolled out and how people were in the global north were being offered booster shots, while the African continent, 95% of people in the African continent hadn't even been offered a first vaccine. So I think the question of solidarity has become very contested, especially with people in the global south asking why, if no one is safe until everyone is safe, why is it that there was such a huge a skewed rollout of vaccines. The point I want to make is perhaps a bit more on the micro level, and the way that I think about solidarity is related to some of the work that I'm involved in around sex work, sex workers, other marginalized groups, homeless, intravenous drug users, and how the rollout of vaccines on a country or a community level created hierarchies about who's deserving and who's undeserving. And we had difficulties in around documentation of you having to show your ID before you can get a vaccine, and not sufficient work that was done on bringing undocumented people into a system to be able to get a vaccine. And that had, from a migrant perspective, the public health principles about everyone having to access a vaccine to make everyone safe was quite hollow. So for me, solidarity extends to thinking. Solidarity extends specifically to health equity around how do we think about undeserved and marginalized groups, and how we provide the resources and the infrastructure to make sure that their access is secured. Then the second point is some work that Lauren and I are involved in around post-clinical trial access of products that were tested on a specific population. We know in South Africa that there were big vaccine trials at the beginning of the testing around vaccines. I was a trial participant in the AstraZeneca trial, and large numbers of participants were drawn from South Africa to test vaccines. But there was no guarantee at the end of the trial that they would be benefiting, or let's say post-trial access to countries that had participated in terms of human resources to the testing of the trials. And I mean, when we look at what the Contracts case brought to light for the AstraZeneca, for the Serum Institute vaccine, South Africa paid 2.5 times as much as the European Union, but yet we participated in the trials to show some of its efficacy. So I think solidarity would also relate to how clinical trials are thought about, and what type of guidelines and regulations are enforced to ensure that there's solidarity across the the access to medicines and therapeutics. I'm going to stop there.
Thank you, Marlise. So you've started to kind of move into the direction of a question that Catherine Littler posted in the chat, which is in a world that seems so overwhelmingly unfair. That's my words, not Catherine's. What does anyone do, right? So where do you start? And I think I partly asked the three of you to speak, well, because I get the sense that all three of you have been involved, not just in scholarship and not just in thinking in the abstract about this imagined better future, but concretely through activism and by doing things. Now, she also asks, what is the role for ethics? And I guess for me, ethics can be very narrow and prescriptive, right? We can talk about ethics as the work that an ethics committee does, but I think ethics is also ultimately about this imagination of a better future, right? This real engagement with ideas around concepts like justice, fairness, equity, and how we would like the world, how we would like to remake the world. So I wonder if you want to speak to either of those two broad observations. So what can anyone do, and what should we do in order to change? You've all three diagnosed this kind of systemic problems that constrain our actions. What do you think we should all do next? I'll take any order that you feel like speaking. Okay, Safura, good.
No, Marlise, please go ahead.
Sorry, I just wanted to make a very small point that I think we were, at least the way that I was speaking was very critical about the lack of solidarity. But I think it is important, and Jantina, your question is so important, to note that there was immense amounts of solidarity from, at least in the international activist sphere that I think we were all involved in how activists and researchers, many researchers, stood in solidarity in advocating, especially around international level, around the intellectual property protections that were being enforced, and how there were very strong, I think, strong echoes around the international activism around HIV and AIDS in the early 2000s. The work that many people were involved in bringing down the prices of antiretrovirals. I think some of those networks and alumni who were involved in those campaigns were reactivated. And I felt very buoyed, especially during the darkest time of the lockdown of the pandemic, to see how international networks stood together and demanded equitable ways of dealing with the pandemic. And I think that was something that was very inspirational. And if perhaps with a little bit more distance from the pandemic, to think about how those networks and that sense of solidarity can be extended and built on in terms of thinking through pandemic readiness and other pandemics, I think is something that we should see as a big resource. So yeah, I just wanted to say that there were a lot of amazing examples of solidarity as well.
Wonderful. Safura?
So I'm going to say something a little bit controversial, but I think my view is that in order to fix this, we need to demand better, but we also need to do better. So one thing I didn't touch on at all when I was making my remarks was about the conduct of people in low and middle income countries when it came to the moment they got a little bit more power than the poorer countries, they engaged in their own forms of vaccine nationalism. So I can speak about South Africa a little bit. For example, we had signed on to COVAX. We said we will participate in COVAX. But how did South Africa actually get its vaccines? It got it through bilateral negotiations, as Marlise has just outlined, because we could afford to pay for vaccines and other countries couldn't. We pulled out of a solidaristic model and went, we come first. And I think we didn't just see that as something that governments engaged in. It was something that the public also perpetuated. So I'll never forget that we had received some doses of AstraZeneca to be distributed in our population. And at the time, the Delta variant was raging through South Africa, and it was shown that AstraZeneca wasn't particularly effective when it came to that particular variant. And so the government decided, in an act of what I consider to be deep solidarity, to donate those doses to the African Union's African Medical Supply Platform, so that those doses could go to countries that didn't have high levels of Delta variant and actually protect healthcare workers in those countries. The public backlash to that decision from scientists and civil society and members of the South African public was astonishing to me. It remains astonishing to me because it reflects how we can so quickly move from demanding solidarity to perpetuating the same kinds of nationalism and apartheid that we complain about. So that's why I was like, I'm going to be a bit controversial and say, I think we need to also walk the walk. We need to say we're not, even though we can conclude bilateral agreements with Pfizer, we're going to choose solidarity. We're going to choose to participate in something like COVAX for all its problems. We're not going to perpetuate the vaccine apartheid that's done so much damage to us. We're going to take the steps to undo it. And I think it's equally true of the vaccine trials. Why did researchers in South Africa say it's totally okay, we'll pay for these trials, we'll perform them here, no post-trial access for our participants? Why was that something that was acceptable? That's why I think when we talk about it, we often talk about it as a global level between countries and governments and regions. There's an individual element to this, of an ideology and an ethos around being solidaristic that's not necessarily being practiced when the rubber meets the road.
Thank you, Safura. Demand better and do better. Provocative and important. Lauren?
Yes, so I mean, a couple of things. I think Safura's comment just struck me about doing better. One of the things that we're privileged to be able to host in South Africa is the WHO mRNA Hub. And that's a platform that's designed to develop mRNA technology so that we can use it for various different interventions, not only influenza, but hopefully other things like HIV, TB, and so on. And I think one of the questions there is if we are able to master the technology and share it, what does the commercialization phase look like? Do we do better? Do we move towards a public ownership model? Do we have a kind of democratic consultation around the pathogens that we prioritize, like Fiocruz does in Brazil, for example? So that would be, for me, a kind of concrete demonstration of a more solidaristic medical manufacturing model, because the other option is also viable and maybe even more viable, that we might end up with, yes, local manufacturing, but profiteering in similar ways to drug companies in the global north. The other part of the answer, I think, is to regulate unethical behavior and to reward ethical behavior. And that sounds simplistic, but I'm thinking, for example, of the great work that South Africans did in sequencing different variants of the COVID virus. So you'll remember that a South African scientist, Dr. Tulio de Oliveira, announced that Omicron had been discovered. This is what it looked like. He shared the information freely with the world. And I think that was a great act of solidarity. It wasn't an attempt to hoard information and monetize it, for example. So you have this act of solidarity and scientific openness. And instead of this ethical act being rewarded, there's blowback, and South Africa and other Southern African countries experience travel restrictions, for example. So, you know, one of the things then when we think about the pandemic accord is where countries share information, will there be due process for unilateral sanctions that follow on sharing that information? So in future, if let's say the EU imposes a travel sanction, can we institutionalize a process in the pandemic accord where that kind of irrational and maybe unscientific action is challenged and rectified? And then in terms of regulating unethical behavior, I think one of the things to think about is regulating some of the commercial actors. Safura has mentioned profit and commercial determinants of health. I think one of the big potentials that comes with the pandemic accord is placing an obligation on countries in both the developed and developing world to regulate for-profit actors that are acting in a kind of extractivist way during public health emergencies and pandemics, and to compel them to share licenses, know-how, other trade secrets in order to increase access to medical countermeasures.
Marlise?
Jantina, I think I've spoke a little bit about the micro level, and I think Safura and Lauren spoke to some of the points that I think are applicable to the broader context.
Brilliant. So there's a provocative for me or really exciting way in which ethics features in this debate. And I just want to draw that out for those of you on the call in the audience listening and thinking, well, I don't recognize this as ethics at all, because for me, ethics is about informed consent. And I think the way that this links is that when our gaze is on the micro ethics, right, on the procedural ethics and the thinking about how we enroll people in clinical trials and whether those trials are conducted ethically and so on and so forth, what we don't then see is that the way that the world is and the way that these bigger systems and what we call the political economy of things like vaccines, for instance, shape health and people's ability to be healthy and to be well, then, you know, the question of whether if someone gives informed consent to participation seems irrelevant or less important or less pressing when we or only partial to this bigger question about how do we live in a world that we all want to live in, right? How do we live in a world where people have equal or equitable opportunities to be healthy or to be well? How do we create a world in which all countries and all governments have the ability to control manufacturing, for instance, medical manufacturing, and so on and so forth? There is a question in the chat, and I've also asked you, we end in about 6 minutes. What I would like to ask you is, and this is perhaps very difficult to do, but I'll ask the three panelists to spend a couple of minutes each reflecting on either of the two questions. The one is, what would go into a framework for vaccine allocation? So what would you prioritize? Would you prioritize countries with the highest mortality, countries with the highest population of people at risk of mortality, countries who participated in vaccine trials, and so on and so forth? So that question you can read in the chat. The other question that I'm really particularly interested in is, what do you think should be the non-negotiables for African governments as they engage in the pandemic treaty or the pandemic accord? So Lauren, you've already said that there is quite a lot of discussion about whether equity-oriented provisions of the accord ought to be legally binding or optional extras. And perhaps you can weave that into your response as well. So I'll give you the choice to answer either or both of those in just a few minutes. Again, maybe reverse order. So I think Lauren went last on the last one. So let's do Lauren, Safura, and then Marlise to round off.
So I'll speak to the one about the non-negotiables in the pandemic accord. So I think maybe three things. One is that there is already an existing legal instrument that governs responses to outbreaks and health emergencies of international concern, the IHR, International Health Regulations. I think one thing is that equity provisions should also be included in that instrument, because already many member states of WHO are party to that agreement. And the risk, of course, is that the pandemic treaty negotiations could fall apart, but we still have the IHR, and so why not also codify binding obligations to promote equity in that instrument? So first prize is both, second prize is IHR. I think the second thing is something I've mentioned, which is that in terms of equity, I would like to say that the equity obligations should be binding, not voluntary. I think one of the things that COVID demonstrated is that voluntary obligations don't get us very far. And I think Safura's discussion of vaccine apartheid shows that. I think Marlise's example of trying to force vaccine companies to sell vaccines at ethical prices shows that. I think states need to be able to exercise some leverage over the infrastructures that promote health equity. And if they have a binding obligation to do so under international law, that gets us one step closer. So I think that's the second thing. And then the third thing, I think, is a red line in terms of any multilateral process is that it should be fair, transparent, and inclusive. And so I think in terms of both the IHR and the IMP processes, it would be great if it was if there was greater openness in terms of the public actually having access to some of the textual negotiations that are being conducted, the informal discussions. It's very kind of opaque. I think one of the other things that's really important procedurally is the Bureau's text not necessarily becoming the default negotiating text, but member state suggestions actually being entered into a negotiating text, and that then being the basis for moving ahead. So I'll leave it there. Thanks, Jantina.
Thank you, Lauren. Safura.
So I'll answer the Q&A question, which I think is quite a traditionally ethics question, which is the one thing I think that the traditional models of ethics struggle a little bit to conceptualize is how rationing and resource constraints fit into these frameworks. So for example, we can say, okay, we should prioritize countries that have populations that are at the highest risk, which would not be African countries, right? Because we have uniformly younger populations, but we have fewer ventilators. So the people, and we have poorer healthcare systems. So the people who do get sick are very unlikely, they're likely to have poorer health outcomes and less likely to receive treatment. So that is one additional fact I would throw in, is this is not just about the front end stuff of who gets sick and who's at risk, but also the back end stuff of when somebody does get sick, what then happens. And I think that that idea of resource constraints and rationing needs to play in a little bit more into our thinkings of ethics, particularly when we're looking at the traditional model that really isn't equipped to deal with issues like that because it's very individual focused. So I won't attempt to answer the other question. That was just something I thought I would put out there for thought.
Thank you, Safura. And then Marlise.
I think just very shortly on the pandemic accord, and I think I would put in a big push for transparency. I think there's some useful provisions in the draft zero, and I think there will still be a lot of contestation as we near the finalization stages. But I think that's some of the lessons learned around the transparency, especially the sharing of information. I think the pandemic accord is clear at the moment in the provisions around sharing information of public money was used for the development of products, which I think there will be pushback against. That as civil society and as researchers, as ethicists, that we are strong advocates for this pandemic treatment process, to include these elements of solidarity and equity and transparency, and that we quite bolshy in our demands on what we need to make it as a piece of solidarity. And I think there's organizations who are pushing really hard for it, but that perhaps in the global health or the public health community, perhaps even in ethics, that there's not been this more strong, a multitude of strong voices to help push that agenda. So I think, in short, definitely transparency and definitely activism to push it through. Thank you.
Wonderful. So thank you to all three panelists. I thought that was a really rich discussion that merited a longer time frame, not just an hour, for us to dive into some of the really interesting aspects of I think ethics that you have raised. What I take away from what you've said is different things. One is it is important to demand better. and demanding better and holding people to account. Marlise, for instance, is the case that you raised is an example of how when we demand better, others can do better too. So we hold people to account, and that's really important. And that's certainly something we can always do. The other thing that I take away is that it's not just important to demand better. This is Safura's comment, but also to do better, and to do better means to act in solidarity, right? Not just in the abstract, but also in the concrete, in the everyday interaction. So doing better is not just for someone else to do better, but for us to do better every day ourselves as well. I thought there were some really interesting ways of thinking about ethics that came through in talking about equity, for instance, and demanding equity in different ways, but also helping everyone think about how to reward ethical behavior and how we engage and reward ethics when we see it. There were some interesting early discussions, I think, around benefits and benefit sharing and access and research that we didn't quite get to, and I see the questions are coming in now. Unfortunately, we're at the end of the hour and the scheduled time for this webinar. I thank you all very much for participating and for bearing with us. Thank you for the interest that you've shown, particularly in the questions that are coming through. You can reach the Epidemic Ethics Network through Facebook, Twitter, and many other social media platforms that I probably do not even know the names of. The lecture was recording, or the webinar was recorded, the discussion, and will be available on the Epidemic Ethics website in a couple of days' time. And rests me nothing but to thank the three speakers. Thank you for making the time. I know how busy this time of year is, so thank you very much, Lauren, Marlise, and Safura for spending this time with us. Thank you to Kevin and Dina and others of the Global Health Bioethics Network and Global Health Network to pull this together, and we hope to see you at future events.